Hi everyone, it's Loretta. I'm going to talk to you about cardiac rehabilitation. This is the recorded version of the lecture that we'll have in class. I don't like long recorded lectures, and so I'm going to cut it up into small sections. And if you want to rewatch it to review, then it's available to you. So first, I'll talk about the learning objectives for the entire day, and then we'll start with a review of normal cardiac function. So the learning objectives are to be able to describe the clinical indications and contraindications for cardiac rehab, describe the three phases of cardiac rehabilitation, the first of which we're usually involved in, and the last two phases are usually done in a cardiac rehab setting, and I'll talk about that. I want you to define those different terms, and we'll talk about those. Describe ways to determine exercise intensity and define energy expenditure. Importantly, I want you to be able to identify the 6 contraindications / termination criteria of discontinuing exercise or cardiac rehab. This is important whether you're working with someone in cardiac with a cardiac issue in an inpatient or subacute setting, or home health, or anything. When are we going to discontinue exercise? That's pretty super important. I want you to be able to accurately measure and document and communicate to PT and other people on the healthcare team, as well as to the patient, ideas about perceived exertion, dyspnea, just difficulty breathing, or angina during activities, and use some different measurement scales to quantify that. I want you to be able to identify and differentiate normal from abnormal cardiopulmonary responses to therapeutic exercise. So this is important not just for cardiac patients, but for all of our patients. And what are the normal and abnormal responses to the performance of activities of daily living and instrumental activities of daily living? So if somebody can't get up, walk to their kitchen, make breakfast, and sit to the table without getting short of breath, that's not normal. So we'll talk about that. So first of all, we'll start with a review of normal cardiac function, and that will be this section of the lecture. So there's our heart, 4 chambers of the heart, 2 atria, 2 ventricles. The atria are in diastole. The myocardium, which is the heart muscle, is relaxing, so we can fill the chambers of the heart with blood. In systole, the myocardium is contracting, which provides the increase in pressure to eject the blood, which is what the heart has to do. The cardiac cycle begins with the atria relaxed and filling with blood. The atrioventricular valves open, blood flows into the ventricles. The atria contract, the remaining blood is forced into the ventricles. The atria relax, the ventricles contract. The atrioventricular valves close, so you don't get backflow. The semilunar valves open, and blood is ejected from the ventricles into the pulmonary artery, going to the lungs. From the right ventricle and from the left ventricle, it's ejected into the aorta. Then the ventricles relaxed and the whole thing starts over. So your heart does that over and over and over again all day, every day for your whole life, hopefully. If it doesn't, then we have a problem. So as the blood is being ejected into the aorta, the very first exit out of the aorta is the coronary circulation. So the blood has to feed it, the heart has to feed itself with oxygenated blood in order to keep working. So the myocardium has a very high demand for oxygenated blood, as does the brain. So those are 2 very important areas that we have to keep going. And the coronary circulation consists of right and left coronary arteries. Coming off the aorta, they branch off the aorta immediately distal to the aortic valve. So before any of the oxygenated blood goes into our systemic circulation, it has to go to the heart first. the coronary circulation is considered part of the systemic circulation. The left coronary artery divides into left anterior descending or interventricular artery. So it goes down right between the ventricles, and the left circumflex artery. The right coronary artery branches into the right marginal artery and the posterior interventricular artery. There are lots of small branches that extend from these arteries to supply the myocardium and the endocardium with oxygenated blood so they can continue to work for us. Very important. And we'll talk about diseases of the coronary circulation in the next section. So cardiac output is basically the heart rate is ventricular contractions per minute, and the normal is a range of 65 to 80. So anything below 65 is considered bradycardia, and above 80 is considered tachycardia. Cardiac output is the amount of blood, the volume of blood ejected by the left ventricle in 1 minute. And normal output is 5 liters per minute. So picture 5 liters right now. And 5 liters per minute is our normal cardiac output. So that's a lot. During exercise, it can go up as much as 20 to 25 liters per minute. Normal output volume per stroke is about 70 milliliters. So you do the math and you can figure that out, what your cardiac output is. So the cardiac output is the stroke volume times the heart rate. Okay, and we'll talk about this a little bit. So stroke volume is the amount of blood pumped out of the ventricle during a contraction, during systole. The preload is the amount of blood delivered to the heart by venous return. And you can think of preload as pre-stretching the cardiac muscle. The afterload is the force required to eject the blood from the ventricles. So afterload is somewhat determined by peripheral resistance in the arteries. So preload is also known as the left ventricular end diastolic pressure. How do you like that? It's the amount of ventricular stretch at the end of diastole. You can think of it as the heart loading up for the next big squeeze of the ventricles during systole. So if you remember from way back in kinesiology, where if you stretch the muscle ahead of time, then you can get a really big contraction. So we're preloading our heart muscle so you can get a big contraction. The amount of blood in the ventricle at the end of diastole is known as the end diastolic volume. It's also the muscle length prior to contractility, and it's dependent on ventricular filling. So it's the amount of blood in the ventricle is related to right atrial pressure, and the most important determining factor for preload is venous return. So if there's some way that your venous return is compromised, it's going to compromise your preload. Okay. Preload and degree of contractility are directly proportional to stroke volume. So if preload goes down, stroke volume goes down, and cardiac output goes down. So hopefully that makes sense. Afterload is the arterial pressure that the ventricle has to push against in order to contract. If arterial pressure increases, afterload increases. Afterload it's the force that the left ventricle has to generate during systole to overcome the aortic pressure and open the aortic valve. So aortic pressure is keeping that valve closed, so you don't have backflow. So the left ventricle has to be strong enough to overcome that pressure and open the valve. If the pulmonary artery pressure determines the afterload for the right ventricle, and aortic pressure determines the afterload for the left ventricle. It reflects the resistance in the peripheral system against which the heart must work. So the afterload is also known as systemic vascular resistance. That makes sense, right? It's the amount of resistance the heart has to overcome to open the aortic valve and push the blood volume out into the systemic circulation. Afterload is inversely proportional to stroke volume. So if the afterload is higher, stroke volume is lower, and therefore cardiac output is lower. So preload, higher the preload, higher the stroke volume, higher the cardiac output. Afterload, higher the afterload, lower the stroke volume, lower the cardiac output. So hopefully that makes sense. So the end diastolic volume is the volume of blood in the ventricle just prior to contraction. That's the most amount that you're going to have in your ventricle. You can think of it as the heart loading up for that next big squeeze of the ventricles during systole. The end systolic volume is the volume of blood in the ventricle at the end of contraction. There's always a little bit. And ejection fraction, which we'll talk about in a minute, is the difference between those two. It's basically how efficient your heart is. The stroke volume is the volume of blood pumped from one ventricle with one beat. So the stroke volume is the end diastolic volume, where it's as full as it's going to get, minus the end systolic volume, which is as empty as it's going to get. So you can see that. You can do the math. You can do the second grade math on that. So cardiac output is the amount of blood pumped by each ventricle in a minute. This is just a review because we have to repeat to remember. The heart rate, it's cardiac output equals heart rate times stroke volume. So heart rate is the number of contractions of the ventricles in each minute. Stroke volume is the amount of blood ejected from each ventricle with each contraction. So if the average heart rate is 70 and the average stroke volume is 70 milliliters, you do the math and you come out with an average cardiac output of 4,900 milliliters or 4.9 liters per minute. Okay, makes sense. The factors that affect that, our heart rate is affected by our sympathetic nervous system. So epinephrine in our sympathetic nervous system can increase the heart rate. So you increase heart rate, you increase cardiac output. The stroke volume is determined by venous return, the preload, the blood volume, the sympathetic nervous system, the contractility of the heart, and the peripheral resistance, which is the afterload. So all of those can affect cardiac output. So the ejection fraction, which I briefly mentioned a little bit earlier, it's the measurement of blood leaving your heart each time it contracts. So remember, we had that end diastolic volume, which is the most your ventricles are going to hold, and the stroke volume, which is what's taking away from that. So normally your heart is pumping 50 to 70% of the blood in the left ventricle with each contraction. That's normal ejection fraction. And that's what they mean by fraction, that 50 to 70%. So that it's 50 to 70% of the end diastolic volume. If your blood is only pumping 40 to 55%, it's likely that you have damage due to a myocardial infarction, and you're probably going to have symptoms associated with that. So symptoms can include shortness of breath, lower extremity edema, fatigue and weakness, abdominal discomfort, and the abdominal discomfort is due to fluid pressure because you're not effectively moving fluids around your body. Below 35% ejection fraction may be evidence of heart failure. If you have chronically low ejection fraction, no matter the cause, that's less than 30%, it qualifies for a disability claim. And below 25% ejection fraction is considered heart failure. Interestingly enough, though, treatments are good enough now that you can see people in the hospital or in skilled nursing facilities with a 10% ejection fraction, which means they're in heart failure, but they're still going along. You can imagine at 30% how that's going to affect your ADLs and your general mobility. At 10%, that's really going to affect your ADLs and your general mobility. So a lot of times in PT, we're working with people that are too sick to go into full cardiac rehab. So we need to really take that into account when we're talking about our exercise. So just a review of the normal conductivity of the heart. Unlike skeletal muscle and smooth muscle in our body, the heart muscle does not have a nerve action from, it's not getting a message from the brain. That's one of the reasons why that is the reason that you can do a heart transplant, because a heart can beat on its own. The myocardial fibers initiate their own electrical impulses. You don't need the brain impulse in order to do that. So if you get a bunch of myocardial cells together in a petri dish, they will start beating because they'll electrically link and they'll start sending out impulses. So that's what myocardial fibers do, and that's why you don't need a brain impulse in order to contract the heart. So the brain affects, the way the brain does affect the heart is through the sympathetic nervous system by increasing norepinephrine, increasing receptors or binding with receptors on the heart cells and increasing the heart rate. So the heart rate is generated from within the heart itself. The normal action is for the original electrical impulse to come from the sinoatrial node in the right atrium. So normal sinus rhythm or sinus rate is about 70 beats per minute. If someone has a pacemaker, they're usually at about 60 beats per minute, because the pacemaker waits until it's going to see if you're going to initiate one on your own. If it doesn't, it gives you a zap. So it's a little behind normal rate. The impulse from the sinoatrial node goes along the atrial conduction pathways. That's considered atrial conduction. That's the P part of the EKG wave. The AV node is triggered by that impulse, and then a short delay before initiation of the atrioventricular bundle, which is also known as the bundle of His. The left and right bundle branches and the Purkinje fibers are triggered, and ventricular contraction occurs, and that's the QRS part of the EKG. And then the ventricular repolarization and relaxation is the T part of the EKG. So we are not, as our main field of practice, expected to interpret EKGs, but it is nice to know what a normal one looks like. And in class, we will watch the YouTube video that's listed here that talks about abnormal conduction of the heart. And then the link is here in case you want to review that.